Hello students, a very good afternoon. I am Dr. Divya Ma'am, Pediatrics faculty with PW MedEd, and we here have devised this amazing series, INICET PYQ series. So if you are someone who has already given INICET once, or if you are someone who is preparing for INICET specifically, then you already know that INICET is very PYQ and PYT heavy. Most of the questions, almost 50% of them, are either direct repeats or they are related to that previous year topic, related to that question. So we have compiled PYQs over the last 5 to 10 years, and this series is aimed at priming you regarding these important topics that you cannot afford to miss in the exam. So there is just a month left in the exam, and here's my take on the Pediatrics PYQ. So without further ado, let's get started. The first question I have is, what is the rate of increase in the head circumference in the first 3 months of life? And the options we have are 1 centimeter per month, 2 centimeter per month, 0.5 centimeter per month, or 2.5 centimeter per month. This trend in the head circumference have been asked twice or thrice in different formats. So let us understand the basics of the head circumference. So when we talk about head circumference in the pediatric population, then how do we measure it? We measure it with a measuring tape. So we take the measuring tape and place it anteriorly just above the supraorbital ridge and posteriorly on the highest point of occiput. This is how we measure. Normal head circumference of a term baby at birth is 33 to 35 centimeters. This 33 to 35 centimeters is actually 65 to 70% of the adult size. Right, this is 65 to 70% of the adult size. Let's see how this head circumference now grows after birth. In the first 3 months of life, the rate of increase is 2 centimeters per month. 2 centimeters per month. After that, 3 to 6 years, the rate of increase is 1 centimeter per month. And after that, in the next 6 months, it's 0.5 centimeter per month. So let us see how will this grow. 2 centimeter per month means 2 centimeter for 3 months, that is 6 centimeter. Then we have 1 centimeter for 3 months, that is 3 centimeter. And then we have 0.5 centimeters for 6 months, that is again 3 centimeter. So in the first year of life, we have a gain of 6 plus 3 plus 3, that is 12 centimeter. So if I take average of 34 centimeter at birth, then at 1 year of age, it will be around 46. After that, in the next 1 year, I have 2 centimeter gain. So at the age of 2 years, the head circumference would be 48 centimeter. And remember, this is 90% of the adult size. This is another PYQ that they ask in the exam, that when does a child achieves a head circumference that is 90% of the adult size. So at 2 years of age, remember, the child attains 90% of the adult size, right? And at birth, it's 65 to 70%. So moving back to the question we have, they are asking in the first 3 months, what is the rate of increase? So the correct answer here would be B, that is 2 centimeters per month. Moving to the next question. I hope the video and audio is fine now. Yes? So let's start with the next question. Another plain growth question. When does a newborn reach half the height of an adult? The options we have are 12 to 18 months, 28 to 32 months, 18 to 24 months, and 32 to 34 months. So when does a newborn reach half the height of an adult? If we take an average height of an adult, so let's take it the average height, it would be around 160 centimeter. So if you divide that, that comes around to be 80 centimeter. So when does the child reaches 80 centimeter, they are asking. So if you take the normal height increased trend, then at birth we know the normal length is, average length is 50 centimeter. And in the first year of life, there is gain in 25 centimeter. So by the end of 1 year, the length of the child is 75 centimeter. And subsequently, there is gain of 10 to 15 centimeter over the next year. So by the end of 2 years, the child would be around 85 to 90 centimeter. So they are asking around 80 centimeter. So it will be close to second year of life. So the most appropriate answer here would be 18 to 24 months. Right? This is again a very frequently asked question. Let's move to the next question. A short stature evaluation question. Short stature is a very favorite topic of INI people. So we are going to discuss different variation of these short stature questions that they ask in the exam. So this question says to calculate the mid-parental height of a male child whose father and mother's height are 185 and 175 centimeter respectively. What would be the mid-parental height over here? The options are 190 centimeter, 170 centimeter, 173.5 centimeter and 186.5 centimeter. So what is mid-parental height? You know, our height varies a lot and genetics play a very important role. I am short because my parents are short. So the parental height determines the final height of a child. So for that we have mid-parental height concept. So what is mid-parental height? This mid-parental height is calculated as average of the parent's height, that is adding the mother's height and the father's height divided by 2, that is the average, and we add 6.5 centimeter if it is a boy and we subtract 6.5 centimeter if it is a girl child, right? So here in this question we have a boy. So for a boy, let's calculate the parental height. 185 plus 175 divided by 2 and we have to add 6.5 centimeter, right? So what would be the answer over here? 185 plus 175 is 360 divided by 2, that is 180. 180 plus 6.5 centimeter. So the answer here would be 186.5 centimeter. Right? So this is about the mid-parental height calculation. This is going to give us the target height. This is the target height of that individual. Moving to the next question. Short stature assessment only. So we have a 14-year-old boy who presents with short stature. So they have already given you that this guy has short stature. That means the height for age of this child is less than -2 standard deviation. This is the definition of short stature, or we can say less than third percentile. Less than third percentile. So this is short stature. On examination, his upper segment lower segment ratio is 0.8:1. What would be the most likely diagnosis over here? And the options we have are spondyloepiphyseal dysplasia, achondroplasia, growth hormone deficiency and hypothyroidism. So for that, let's first understand this ratio, that is the upper segment lower segment ratio. So if we talk about this upper segment lower segment ratio, this is very important for us because it helps in differentiating disproportionate short stature from a proportionate short stature. So what happens if I take this as a line diagram as a child? This upper segment lower segment ratio tells me the maturation. You know, the growth of the body, the somatic body growth, it happens in cephalocaudal direction. Cephalocaudal direction, and within the limbs it is it is distal to proximal. That means my hands will grow first, then the forearm, then the arm. So cephalocaudal and distal to proximal. So that means if you have ever looked at a newborn child, the head is comparatively bigger from the body, and as the child grows, trunk grows, the limbs grow. So at birth, I know the head is going to be big, the lower segment is going to be short. So what is upper segment? Upper segment is from the top of the head till the pubic symphysis. This is the upper segment, and subtracting that from the height of the child is the lower segment. So at birth, definitely this upper segment is bigger as compared to my lower segment. So at birth, what is the normal upper segment lower segment ratio? The normal upper segment lower segment ratio at birth is 1.7:1. At 3 years of age, it becomes 1.3:1. At 6 years of age, it becomes 1.1:1. And as the child approaches 10 years of age, it becomes the adult, close to the adult ratio, 1:1. And after that, adult ratio is achieved, that is 0.9:1, or it can also be written as 1:1.1. So as the child grows, the lower segment grows, so this ratio decreases. So this is the normal ratio. If a child with short stature has normal ratio for that age, this is a proportionate short stature. But if the ratio is either high or low, that would be a disproportionate short stature. So disproportionate short stature can be either, we can either have a increased upper segment lower segment ratio, or we can have a decreased upper segment lower segment ratio. Increased ratio means my upper segment is big, lower segment is short. So this is short limb dwarfism. Short limb dwarfism. And there are only 3 examples that you need to remember for your exam. And if I wake you up in the sleep and ask you these 3, you should answer me, right? Remember these 3. Short limb dwarfism. What are these 3? First is rickets. Second is achondroplasia. And third is congenital hypothyroidism. Congenital hypothyroidism. Right? What about the second category where the upper segment lower segment ratio is actually decreased? That means my upper segment is short and my lower segments are normal. So this is short trunk dwarfism. Short trunk dwarfism. Here my trunk is short. So trunk mainly is composed of spine and your rib cage. So any problem with the spine can lead to a short trunk. So this includes conditions like affecting the spine like vertebral anomalies. There can be spondyloepiphyseal dysplasia. Pot spine. And storage disorders like mucopolysaccharidosis. So this is all about the evaluation of short stature and how do we utilize this upper segment, lower segment in determining disproportionate short stature. So here in this question, they have given us a 14-year-old boy. So normally at 14 years of age, the upper segment, lower segment ratio should be 0.9:1. But here the ratio is less. Here the ratio is decreased. So that means my upper segment is short. There is short trunk dwarfism. Short trunk dwarfism. And I told you all the spine conditions will come into this. So spondyloepiphyseal dysplasia is the correct answer over here. Achondroplasia is short limb dwarfism. Here the upper segment lower segment ratio would be increased. Same is for hypothyroidism. And what about the growth hormone deficiency? Growth hormone deficiency causes a proportionate short stature. So here I will have a normal upper segment lower segment ratio. Right? So this is about how we utilize this upper segment lower segment ratio in the evaluation of short stature. Moving down to the next question. What is the last sign of puberty that is seen in girls? We have options as thelarche, menarche, pubarche, adrenarche. Right? Thelarche, menarche, pubarche, adrenarche. So what is the sequence of puberty? What is puberty? Firstly, tell me. Puberty is nothing but appearance of secondary sexual characters, and these thelarche, menarche, pubarche, adrenarche are nothing but these secondary sexual characters. Sequence is what they are fond of asking in the exam. Yes, Lakshman, TPM. You remember the sequence as TPM. T is thelarche, P is pubarche, M is menarche. And same goes for males, the same mnemonic, TPM. T is for testicular enlargement, P is for pubarche, and M is for manly, that the boy will turn manly, that means will have beard, facial hair, deepening of the voice. Right? So here they were asking about the last sign of puberty. So by the sequence TPM, menarche would be the correct answer over here. Right? Let's move to the next question. What is the reliable indicator for both acute and chronic malnutrition? And the options we have are weight for age, height for age, weight for height, height for weight. So malnutrition and nutrition in general is one of the topics that again INICET people are very fond of asking. After neonatology, if one topic they give each and every time is this malnutrition. Either they're going to give you assessment of the malnutrition, or even one or two facts like this, or SAM. Right? So what is this acute and chronic malnutrition? So in acute malnutrition, what happens? For a short period of time, acutely, the child is going to have less intake. So firstly, the weight would be affected. And thereafter, if this malnutrition continues over a long time, height would also be affected. That will be the chronic malnutrition. So let us understand the differences now. Acute versus chronic. So what happens in acute? There is an acute insult, either the intake is less or there is some illness. So weight for age would be affected. True, my weight for age will be decrease. What about the height? Height won't be affected in acute scenario. So height for age would be normal. What about weight for height? Weight for height would also be decreased. Height is normal, weight is decreased. Right? So this would be the pattern in acute malnutrition. What about chronic malnutrition? In chronic malnutrition, along with the decrease in weight for age, height for age would also be decreased. And what about the ratio weight for height? Weight is also affected, height is also affected. So this weight for height may be normal here. Right? So what is common over here? What is the common finding? Common finding is weight for age. So weight for age is a common determinant to both acute as well as chronic. Then what they ask next? They ask what is the best marker for acute malnutrition. So you can see in acute malnutrition the best marker is this, weight for height. So this is the acute malnutrition marker. Then they ask what is the marker for your chronic malnutrition. So height is affected. Height for age is the best marker for chronic. Best marker for chronic malnutrition. So in this question they were asking which is indicator for both. Both is weight for age. Weight for age. Right? So let's move to the next question. Find the incorrect match amongst the following. A developmental milestone question. Skipping 4 years, riding tricycle 3 years, draws a triangle 3 years, scribbles 15 months. So skipping 4 years is correct or not? Hopping, skipping. So remember, hopping, skipping, or skipping on 1 feet. Hopping or skipping on 1 feet comes at 4 years. Skipping comes at 5 years. So they're asking skipping, this is correct only, right? Because at 4 years of age, child can skip on 1 feet. And after that, at 5 years, skipping on 2 feet can be done. The rope skipping, right? Riding tricycle, it comes at 3 years. Drawing of a triangle comes at 5 years of age. 5 years of age, right? So this is incorrect. Scribbling comes at 15 months. So here the correct answer, incorrect match here is the drawing of a triangle at 3 years of age, right? Tariq is asking what adrenarche means. Adrenarche is nothing, just the appearance of the pubic hair. Pubarche, adrenarche is the same thing. Okay, so SAM question is the next question. So they're asking, all of the children below can be diagnosed with SAM except option A is a 2-year-old child with kwashiorkor, 4-year-old child with weight for height -3 standard deviation, 7-month-old child with MUAC 11.4 centimeter, and 2-year-old child with weight for age -3.2 standard deviation. So this question is primarily testing your knowledge whether you know the definition of SAM or not. So how do we define SAM? If you talk about the definition or criteria of SAM, what is that? It says to diagnose a child with SAM, that is severe acute malnutrition, you need anyone I need, right? What anyone I need? I need either there should be severe wasting, that is the weight for height of that child should be less than -3 standard deviation. This is severe wasting. Second is for 6 months to 5-year-old child, that the MUAC should be less than 11.5 centimeter. And the third is that there should be edema. This is nutritional edema. You rule out other causes of edema. So this is nutritional edema. Right? I need anyone out of these. Anyone would fit the criteria. So let us look at the options. First option says there is a 2-year-old child with kwashiorkor. Kwashiorkor, the hallmark is edema only. So this child is definitely SAM. Satisfied my third point. Then we have a 4-year-old with severe wasting. Weight for height is -3 standard deviation. So this is again SAM. Then we have a 7-month-old child with MUAC less than 11.5. Here the MUAC is 11.4. So this is again SAM. Then we have a 2-year-old child with weight for age they have given. Weight for age they have given. Weight for age is not a criteria in SAM. So this would be the bacha with does not have SAM. So all other children have SAM. This fourth is doubtful. This cannot be SAM because this is not fitting into my definition of SAM. Right? So this is all about your SAM and criteria. Remember, anyone you need. Right? Some people ask, ma'am, if the child is given as more than 5 years or less than 6 months, then you have these two criteria, no? Follow these. Only MUAC is the criteria that is specific for 6 months to 5 years of age. The other two, if satisfied, this child is SAM. So remember, don't take that misconception that SAM can only be from 6 months to 5 years of age. SAM can be any child. You just need one criteria to be fulfilled, right? So now let's move to the next question. Reason for refeeding syndrome. Options are increase in the insulin, decrease in the insulin, both, none of the above. So what is refeeding syndrome? Refeeding syndrome is one of the complications that we see in the rehabilitation phase. So whenever we are managing a SAM child, we have two phases in the management. In the first phase, we stabilize the child. That is the first week of admission. We firstly stabilize the child, maintain the acute complications, electrolyte imbalances if any, treat infections if any. That is the stabilization phase in which we stabilize the child, and after that comes the rehabilitation phase in which we are just focusing on rebuilding the wasted muscles of that child. We are going to catch up the growth, increase the feeds, take care that during that period hypoglycemia and other things don't happen again. So we are just rebuilding, we are just providing rehabilitation over here. So in this phase, certain complications happen. And this refeeding syndrome is a very frequently asked one in the exam. So what happens in refeeding syndrome? Remember I told you there are two phases, stabilization phase and rehabilitation phase. In stabilization phase, you just stabilize the child. So when we are in the stabilization phase, we don't start giving too much feeds. We start with slowly, less amount of feeds, less amount but frequent feeds. And as soon as the child goes into the rehabilitation phase, we increase the energy density of the feeds, because now I have to build the muscles of the child. Right? We have to rebuild the wasted muscles. So what happens during this period, during the rehabilitation phase? Because I am introducing high energy dense foods, there will be hyperglycemia. To counterbalance that sugar, my body will start to secrete more insulin. And what does this insulin does? Insulin brings in potassium, magnesium, phosphate into the cell. So there is intracellular transport of these ions into the cell. So there will be hypokalemia, hypomagnesemia, hypophosphatemia. So this is nothing but refeeding syndrome. So this is refeeding syndrome. We see during the rehabilitation phase that the high energy feeds will increase my insulin, that will cause hypokalemia, hypomagnesemia and hypophosphatemia. And they ask which is the hallmark or characteristic feature of this refeeding syndrome. Remember, the hallmark is hypophosphatemia. Hypophosphatemia. Right? Hypophosphatemia. So the question, coming back to the question was reason for refeeding syndrome. So we understood the reason. It is increase in the insulin A. Right? So this is about refeeding syndrome. Let's move to the next question. Best alternative to mother's breast milk in a low birth weight baby is? The options we have are cow's milk, preterm formula milk, term formula milk, or human donor milk. So remember, whenever we're talking about breast milk, the best is mother's own milk. It is also known as mom, mother's own milk. So mother's own milk is superior to anything else in the world. But if due to some reason mother's own milk is not available, the second preference would be donor human milk. Donor human milk. So there are now a lot of milk banks available where mothers willingly can donate their milk for babies who are not getting mom. Right? So donor human milk would be the second preference. After that, it would be your formula milk. And lastly, it would be animal milk. Right? So here the best alternative, straight away answer, it's human donor breast milk. Moving to the next question. Which of the following features indicate a proper breastfeeding position? Chin touching the breast? True, this is correct. Lower lip turned inwards? This is wrong. Lower lip should be pouted out. Lower lip should be everted, not inverted, right? So this is wrong. Upper part of the areola more visible than below. This is again true. We say that the lower areola should not be visible. Upper areola can be visible, but lower should be covered. So this is also true. Baby's cheeks are full and rounded. This is also true. So 1, 3 and 4 is the correct answer over here. So let's understand the proper breastfeeding position or the perfect latching position. So 4 points you have to take care of now. Look at the good attachment. In good attachment, firstly, baby's chin is touching mother's breast. touching mother's breast. Right? This nose should be cleared off. Lower lip should be everted. Right? Mouth should be wide open. And lower areola should not be visible. Should not be visible. So these are the 4 important signs of good attachment of the baby. Very important. If there is poor attachment, what will happen? Baby would just stuck on the nipple, won't be pressing over the sinuses that actually release the milk. So baby will try to suck on vigorously. Mother will have a lot of pain. There will be nipple crackling, nipple infection could be there. So it's very important that you counsel the mother regarding signs of good attachment. They're again very frequently tested as INI. Apart from this good attachment, they also ask about the position in which you breastfeed the child. So remember, how do we breastfeed? What is the position that is recommended? The baby should be in a straight line. That means the body and the head of the baby should be in the same plane. Baby's abdomen should be touching the mother's abdomen. Mother should be looking at the baby. Right? So this would be the ideal position. Right? So remember, good position and good attachment are very important while breastfeeding. Let's move to the next question. Which of the following infants have the lowest risk of getting hypoglycemia? We have a baby born to a mother who's treated with beta blockers, infant of diabetic mother, appropriate for gestational age babies, and IUGR babies. Neonatal hypoglycemia is very favorite of INI. I have given your UG PG exam. I've given the SRship exam in INI in AIMS also, and the SS exam also there, just for the sake of giving exam. So in all the 3 exams, I have seen neonatal hypoglycemia question. So this is such a favorite question of the pediatrics department of AIMS that I'm pretty sure that every other INI has this one question in one form or the other. So what is neonatal hypoglycemia? How do you define neonatal hypoglycemia? Blood sugar less than 45 is considered as neonatal hypoglycemia. So what all babies would be at risk of hypoglycemia? Simple concept. Small baby will have less reserves, so more prone to get into hypoglycemia. So what are these small babies? These would be low birth weight babies, preterm babies, small for gestation age babies, right? And if it is a big baby, then the demand will be more. So again, the baby would be more prone to hypoglycemia. So it will be large for gestation age babies, infants of diabetic mother. Then comes sick babies. Sick babies, in sickness also the demand increases. So again prone to hypoglycemia. If the baby is not receiving oral feeds but getting nutrition through parenteral route, that is total parenteral nutrition, through IV line if the baby is getting nutrition, again there are chances that the baby can land up into hypoglycemia. And lastly but not the least, if there is IUGR, morphological IUGR, this baby also has less stores, so more chances of hypoglycemia. If the baby has some family genetic problem of hypoglycemia, this baby again would be prone to hypoglycemia. So let us make down this list. Firstly, I told you small babies. So small babies, birth weight less than 2 kg, prematurity less than 35 weeks, small for gestation age. All these are chotu babies, small babies, more prone to hypoglycemia. Then we have big babies, that is large for gestation age and infant of diabetic mother. If the mother is on drugs like beta blockers, propranolol, oral hypoglycemic agents, then the baby again is more prone to hypoglycemia. If there is IUGR, if there is Rh hemolytic disease, in sickness, congenital forms of hypoglycemia, and lastly if the baby is on total parenteral nutrition. So remember these 12 points, these all babies are more prone to hypoglycemia. Here the question was asking which of these has the lowest risk. So mother born to beta blocker has a risk. Infant of diabetic mother has a risk. IUGR baby has a risk. And appropriate for gestational age baby does not have that risk. So the lowest risk for getting hypoglycemia is nothing but option C, that is appropriate for gestational age babies. Raju is asking the difference between term and preterm formula. So in term and preterm formula, the main difference, if I tell you, we're going back. So in formula milk, if I tell you about the preterm and the term, so broadly remember in preterm formulas, the concentration of sugar would be higher, right? We usually says that preterm milk, preterm mother milk has some things extra that can be remembered by the mnemonic fine sips. F, more fats, S, more sugar, more iron, immunoglobulins, more proteins, and more sodium. So this is a few things extra that we add for preterm babies just for the sake that they have more requirement. Let's move to now the favorite topic of INI people, that is neonatal resuscitation protocol, NRP. One question you will surely find. It would be either linked to the algorithm of NRP or the devices used in NRP or some random facts about NRP. You are going to find NRP here and there in INICET exam. So the question here is about golden 1 minute. They're asking PPV after birth should be started within 30 seconds, 60 seconds, 45 seconds, 2 minutes. So what is the correct answer over here? The correct answer is B, that is 60 seconds, 60 seconds. So if you look at this algorithm of NRP, can you see there are certain things that are given in the diamond and certain things that are given in this rectangle? So what is this diamond and rectangle? This diamond are the questions that you're going to ask, and this square or rectangle are the actions that you do. So as soon as the baby is born, we do ask 3 questions, TTC, term, tone, cry. Is the baby term? Is the tone of the baby good? Has the baby cried? If the answer to all of these questions is yes, then we just do the routine care. We'll maintain the warmth, we'll start breastfeeding, we'll give vitamin K prophylaxis, rooming in with the mother. But if answer to any of these questions is no, then we have to give initial steps of resuscitation. What are these initial steps of resuscitation? We warm up the baby, position the baby, suction the secretions are there, and do tactile stimulation. If the baby is not responding to these and still the heart rate is less than 100, the baby is apneic or gasping. Remember these 3 points. Heart rate less than 100, apneic or gasping. Then we have to start positive pressure ventilation. And this positive pressure ventilation should start within 1 minute of birth. This is known as golden 1 minute, right? So like Bollywood movies, you don't go on and slapping the baby, stimulating the baby for 1 hour or so. Just you have to do all of these things: warmth, suctioning, positioning, and stimulation. This all has to be done within 1 minute. And if PPV is required, it should be started 1 minute, within 1 minute after birth. This is the golden 1 minute. So this was the question, that the PPV after birth should be started within 60 seconds, that is 1 minute. This is known as the golden minute. Right? Now let's move to the next question. We have all of the following are the indicators of bag and mask ventilation, except the options we have are heart rate less than 100, apneic, gasping, labored breathing. So coming back to this, I told you if any of these 3 is there, heart rate less than 100, apneic, gasping, then we start this positive pressure ventilation. This positive pressure ventilation I can either give by bag and mask or I can do intubation. Bag and mask is easier. You can also do it. You just have to place and make an appropriate seal with the mask and give ambu bag breaths, ambu breaths. Endotracheal intubation is slightly more difficult. You will need a pediatrician like me to do intubation, right? So by any of these means you can give positive pressure ventilation. So they are asking about the indication only for that. So these are basically the indications of positive pressure ventilation. Three things were there: heart rate less than 100, apneic or gasping. If there is labored breathing, you don't start bag and mask ventilation. You take this child on CPAP therapy, that is continuous positive airway pressure, CPAP. If the child's heart rate is more than 100 but the child has labored breathing, then I will take this child to NICU, admit to NICU and give CPAP therapy, right? So this was about this question. Remember, if these are the three indications for starting PPV: apneic, gasping or heart rate below 100. If none of these is there and labored breathing or persistent cyanosis is there, then you consider CPAP. Consider CPAP, right? Okay, so let's move to the next question. Which of the following is the best indicator for the adequacy of ventilation as per NRP? The options we have are chest rise, improvement in the heart rate, improvement in the color, air entry. Remember, when we started NRP, we started with this ventilation only. Whenever I teach NRP, I tell students that remember, babies are born with a good heart and bad lungs. Good heart and bad lungs. So firstly, I have to focus on the lungs. Firstly, I have to focus on effective ventilation. And effective ventilation, most important and effective action is the ventilation of the baby's lungs. So this is the core of NRP. Effective ventilation is the core of NRP. So as soon as anything happens, if the baby is not responding, I will start with ventilation. If the ventilation is not giving adequate results, I will do ventilation corrective steps. Even after effective ventilation of the baby is not responding, then I will start chest compressions. Right? So here, the question was asking which is the best indicator for effective ventilation. If my ventilation is good, heart rate will increase. So the best indicator is improvement in heart rate. Right? Moving to the next question. A term neonate was found to be in respiratory distress, tachypnea and scaphoid abdomen. That means hollow abdomen. Scaphoid, you understand, board-shaped abdomen. So the baby is lying like this. The abdomen would be hollow. Scaphoid abdomen. On auscultation of the chest, there are gurgling sound heard on the left side. Which of the following would be avoided in resuscitation of such a baby? Positive pressure ventilation, bag and mask, ET intubation, oxygen supplementation. So firstly, tell me what is the diagnosis over here? Respiratory distress, tachypnea, scaphoid abdomen. On auscultation, you have gurgling sounds in the chest. What is this? This is nothing but congenital diaphragmatic hernia. What happens in congenital diaphragmatic hernia? Look at this. In congenital diaphragmatic hernia, the name itself says, diaphragm, you all understand, muscle that separates my thorax from my abdomen. So if there is a defect in that diaphragm, what will happen? The contents of the abdomen will migrate to the thorax. This has what happened. You can see gut loops have migrated into the chest. So by this migration, what is the problem that is happening? It won't allow the baby's lungs to expand. So the lungs would be hypoplastic. I will have pulmonary hypoplasia, pulmonary hypertension. And after birth, this child definitely is going to have respiratory distress. And because the contents of the abdomen has migrated into the thorax, abdomen will look hollow. This is scaphoid abdomen. And on auscultation, you will hear the sounds of the gut, the gurgling sounds. So this is congenital diaphragmatic hernia. Importance here is that I should not give bag and mask ventilation. Bag and mask ventilation is contraindicated in congenital diaphragmatic hernia. Why? What I am doing in bag and mask, I am covering the nose and mouth of the baby and giving breaths through that mask. So that means the air is going into both the pipes, wind pipe also, food pipe also. That means some amount of air is also going to my gut. So the gut expansion will further impact my lungs expansion. So that's why bag and mask is contraindicated. Here, if I want to give positive pressure ventilation, I have to intubate a child, right? So here the appropriate answer would be bag and mask. This is avoided. PPV we can give, but through endotracheal tube. Endotracheal intubation we can give, oxygen supplementation we can give. So what is avoided? Bag and mask ventilation is avoided. Moving to the next question. What is the delivery procedure to be done in a newborn? Delivery through meconium stained liquor. Before delivery of the shoulder, suction of the mouth and nose. PPV in a non-vigorous child after initial steps. Gentle suctioning of a vigorous baby. Tracheal suctioning followed by mouth suctioning. So let's understand what is this meconium stained liquor babies. So it is an earlier concept. Earlier, these MSL babies were divided into vigorous babies and non-vigorous babies. So these vigorous babies are those babies that were born via this meconium stained liquor but had heart rate above 100. So that's why they were known as vigorous baby, or activity is good. Activity good, heart rate more than 100. So in these babies, just routine care was given, no extra thing was done. Then came the non-vigorous babies, where the heart rate is less than 100 or the activity is poor. In these babies, we had to start this positive pressure ventilation according to the NR. So no special thing is done nowadays. No tracheal suctioning is to be done, no additional suctioning is to be done, no routine suctioning has to be done. Right? So here, let's look at these options. Before delivery, suction on the mouth and nose. Not recommended. PPV in a non-vigorous child after initial steps. True. Gentle suctioning of the vigorous baby. If suctioning required, then we have to do, otherwise not. Tracheal suctioning followed by mouth suctioning. This is again not recommended. So the correct answer here would be 2 and 3. 2 and 3. Remember, just nothing different has to be done in MSL babies now. You have to treat the MSL babies as normal babies only. If it is non-vigorous, then definitely we will do the initial steps of resuscitation and positive pressure ventilation and the further steps. But if the child is absolutely normal, vigorous, heart rate is good, activity is good, then nothing has to be done. You don't have to vigorously do suctioning in that baby. Don't necessarily need to do tracheal suctioning in the baby. So this is all about the MSL babies. What will be the initial feeding method for stable 33 weeks preterm baby? Nasogastric feeds, oral pallidi feeds, direct breastfeeding, or IV fluids? What do you think would be the correct answer over here? Feeding of babies, preterm babies. So if it is a term baby, I have no problem. I can directly put the child to the mother's breast and the baby can enjoy direct breastfeeding. But preterm babies, feeding in preterm babies is slightly complicated. It depends upon the maturity of the baby. For normal breastfeeding, I need 3 reflexes. I need rooting, sucking, swallowing, and a proper coordination between the two. And also I need the maturity of the gut to handle such feeds. So depending upon the gestational age and the maturity, my choice of feeding would be different. Firstly, let's understand the differences over here. First category is very preterm, extremely preterm babies, less than 28 weeks. What happens in these babies? These babies are very preterm, right? Extremely preterm. Here the gut maturation is absent. Gut maturity is absent. So I cannot introduce feeds into the gut of the baby. Here in this case, I will give parenteral nutrition. We can't give enteral nutrition over here because gut maturity, the gut motility is absent. So here you are going to give TPN, that is total parenteral nutrition. As the child matures 28 to 31 weeks, now the gut maturity is there. But the rooting, sucking, swallowing, these reflexes are not developed. So what will you do here? Gut is mature. I can directly place a tube into the gut and give feeds through that. So here we will do tube feeding, either nasogastric tube feeding or orogastric tube feeding. So NG or OG feeding. Then comes 32 to 34 weeks. Here now rooting, sucking, swallowing has appeared. But there is no proper coordination. No proper coordination between these. So baby can root, suck and swallow, but that is not very effective, not very well coordinated. So here what we can do, slowly we can give feeds through Katori spoon. This is known as Katori spoon feeding or pallidi feeding. And after 34 weeks, all of these are there and there is proper coordination too. So I am going to give direct breastfeeding. Right? So let's move to our question. They were asking about stable 33-week old. So we understood that 33-week would be in this bracket. Here we'll give pallidi feeding, oral pallidi feeding. Moving to the next question. On day 6 of life, a very preterm baby is receiving 30 ml per kg of enteral feeds. Suddenly, this child developed significant abdominal distension with apparent bowel loops. There is lethargy, fluctuating temperatures, and portal venous gas is visible on the X-ray of the abdomen. What would be the NEC staging over here? Options we have are 1B, 2A, 2B, 4. What is this condition and what is the staging they are talking about? So condition you have already read in the question stem. It is NEC. What is NEC? NEC stands for necrotizing enterocolitis. Necrotizing enterocolitis. So the name itself has enterocolitis. That means there is inflammation of the gut, the small intestine and the colon. Usually the terminal ileum and the ascending colon are affected over here. And this inflammation leads to necrosis and perforation finally of the gut. The risk factors here are prematurity, giving formula milk to the baby, and in term babies, perinatal asphyxia, if the mother has cocaine problem, cocaine abuse problem, in all of these conditions, this condition necrotizing enterocolitis can happen. What we are interested over here is staging of NEC, that is also known as modified Bell staging. Modified Bell's staging. So what is this Bell staging? We have 3 stages. Stage 1, stage 2, stage 3. As we go from stage 1 to stage 3, obviously the grade or the severity of the disease is going to increase. In stage 1, what happens? In stage 1, there is just inflammation of the gut that is happening. So this child will present to you with feed intolerance. That means there will be abdominal distension, there will be vomiting, there will be lethargy. Sometimes there can be blood in stools. So what you are going to see over here, we can see feed intolerance, non-specific signs, vomiting, abdominal distension, and blood in stools. In this first stage, you won't see much changes in the imaging. So the imaging might come out to be normal over here. Just the gut lining is starting inflamed. So you see all of these clinical signs. Depending upon the presence of stools in the blood, we can classify the stage into two categories, 1A and 1B. If there is gross blood and stools, that is grossly, you can visibly see that there is blood and stools. Even mother can tell you that, look doctor, the stools have blood. This is 1B. So if there is gross blood in stools, it is 1B. But if there is occult blood, that is, you have to look the stool under microscope to see RBCs, then it will be 1A. Right? Moving to the second stage. In the second stage, now the child is turning more sick. There will be more sick, more lethargy. Also, we see a typical triad that is known as the metabolic triad over here. What is this metabolic triad? We see metabolic acidosis, we see hyponatremia, and we see thrombocytopenia. So this is the metabolic triad that you see from stage 2 onwards. And what are the imaging finding? Depending upon the imaging finding, we can divide this class 2 or stage 2 into 2A and 2B. 2A and 2B. What is 2A? In 2A, you see that the air has started to go and get wrapped in between the lining of the intestines. Right? So if this is my intestinal lining, I will see air trapping within the intestine lining, right, within the wall of the intestine. This is known as nematosis intestinalis. So in 2A, you see this finding, nematosis intestinalis. And in 2B, I see air trapping within the portal venous gas. So portal venous gas, this is known as nematosis portalis. Nematosis portalis. That is air trapped in the venous gas. And lastly, we have stage 3 where now full-blown perforation has happened. So you will have signs of peritonitis like guarding rigidity. So peritonitis feature is 3A. And 3B would be pneumoperitoneum. So examiner mainly focuses on these points. In stage 1, the examiner is going to ask 1A, 1B. So remember, 1A, 1B is on the clinical feature. Occult blood is 1A, gross blood is 1B. Then they ask 2A, 2B. What is 2A, 2B? Both are imaging features. 2A is pneumatosis intestinalis, 2B is pneumatosis portalis. That is air trapped in the venous gas, in the portal vein. Then we have 3A, 3B. 3A is a clinical feature, peritonitis, and 3B is full-blown perforation, pneumoperitoneum, that is air under the diaphragm you see on X-ray. So in this question, we have seen portal venous gas. So this is nothing but 2B, stage 2B. Okay. So my recorded lectures would be soon available. Recording has been done. Expect the lectures to be coming in 2 to 3 days. So don't worry, recorded lectures would be soon available on the app. Moving to the next question. Which of the following is the criteria for perinatal asphyxia? Hypocalcemia, hypotonia, cord blood less than 7.2 pH, or hypoglycemia. So what is perinatal asphyxia? The name itself says perinatal, that means at the time or around the time of delivery, the child has asphyxia, that is the oxygen levels have decreased. So if the baby does not cry after the birth, the baby can have this perinatal asphyxia. The first cry is very important because as the first cry happens, there is influx of the oxygen and the vital organs like brain, gut, kidneys, they all get oxygen. So if the baby does not cry at birth, what is going to happen? These important organs are deprived of oxygen and that can lead to problems in the future. So what exactly is the definition of perinatal asphyxia? So here I'm going to tell you three definitions actually. First definition is the WHO definition. What does WHO said? WHO, very simple people. They said if the baby does not cry after the birth, does not initiate breathing after the birth, or did not sustain breathing after the birth, that is perinatal asphyxia. Very simple, failure of initiation of breathing or sustainment of respiration. This is nothing but perinatal asphyxia. So WHO people were very simple and sweet and gave the sweet definition. Then came NNPD. What is NNPD? National Neonatal Perinatal Database. National Neonatal Perinatal Database. They came and said that WHO, you gave a very simple definition. Medical students should be tortured. They should be given very difficult definitions to remember. So let me complicate this definition. So NNPD gave the definition on the basis of APGAR score. APGAR score at 1 minute. They said if the APGAR score at 1 minute is 4 to 6, this child has moderate asphyxia. And if the APGAR score is less than 4, then this is severe asphyxia, right? So this was the definition given by NNPD. Then came AP, AAP. What is this AAP? This is not Aam Aadmi Party. This is American Academy of Pediatrics. So what did AAP say? AAP said that NNP again has given very simple definition. Let me complicate the definition even more. So these AAP people, on the basis of the pathophysiology of perinatal asphyxia, gave the definition. So what is happening in asphyxia? There is basically hypoxia. So this will affect my major organs. Whenever there is hypoxia, what type of respiration is going to be there? Aerobic respiration or anaerobic respiration? There will be anaerobic respiration. And we all know what is the byproduct of the anaerobic respiration. That is lactic acid. Right? So there will be acidosis in the cord blood. And not just acidosis, there will be very profound acidemia. pH less than 7 is seen in cord blood. Then this hypoxia, I told you, are going to affect my important organs, and one of them important organ is brain. It will lead to HIE, hypoxic ischemic encephalopathy, and it is also going to affect my other organs, so there will be multi-organ involvement too. Out of these, the most common one is kidney that is affected. Right, so depending upon this pathophysiology, this definition was devised. Firstly, they said there will be profound acidemia, pH less than 7 in the cord blood, APGAR score at 5 minutes less than 4, evidence of CNS dysfunction, my brain problem, and other organ, multi-organ dysfunction. So the pathophysiology they included in the definition. So remember these three definitions and let's come back to the question. So hypocalcemia, hypotonia, cord blood pH, hypoglycemia. I know cord blood pH should be profound, less than 7. So this is not a criteria. Hypoglycemia, not a criteria. Hypocalcemia, not a criteria. But hypotonia tells me problem of the brain, the CNS dysfunction. So this is included in the criteria. The correct option here would be B, hypotonia. Right? So this is all about your perinatal asphyxia. Now let's move to the next question. A child was brought to the pediatrics clinic for the management and assessment of quadriplasia. Which of the following MRI findings will be seen in this child? Basal ganglia calcification, periventricular leukomalacia, cerebellar degeneration, or multicystic encephalomalacia. So to understand this, let's understand the brain injuries that we see in neonates. So when we talk about brain injury, in term babies, the most common cause of brain injury is perinatal asphyxia. That is, at the time of the birth, the baby did not cry and there was hypoxia and damage to the brain. So in term babies, the problem here is perinatal asphyxia, the most common problem. perinatal asphyxia. And in perinatal asphyxia, the area that is involved is the parasagittal area. You understand the sagittal plane, this is the midline plane. So parasagittal area. So if you take the motor homunculus, the parasagittal area would be somewhere here. This is the parasagittal area. So what all things would be involved? My lower limbs would also be involved, my upper limbs would also be involved. And lower limbs more than upper limbs would be involved. So there will be involvement of the lower limbs as well as the upper limbs because there is affection of parasagittal area. So because both upper limbs and lower limbs is involved, this will be spastic quadriplasia. Spastic quadriplasia. And as these brain lesions progress, they present to me with multicystic encephalomalacia. Multicystic encephalomalacia. And in future, this child is going to develop a spastic quadriplegic CP, cerebral palsy. This was about term babies. Now let's talk about the preterm babies. What is the brain injury that you see in preterm babies? Preterm babies, the most common brain injury is intraventricular hemorrhage. What happens in preterm babies? This ventricles, surrounding the ventricles, we have an area that is known as germinal matrix in preterm babies. This germinal matrix has very fragile blood vessels in them. So by the manipulation of the baby via delivery, these small blood vessels are very prone to bleeding, prone to rupture. So there will be intraventricular hemorrhage. And if there is intraventricular hemorrhage, this can extend to cause hemorrhagic infarct and extension into the parenchyma. So here the area that would be affected would be around the ventricles. So IVH is the problem, intraventricular hemorrhage is the problem that we see in preterms. And here the area that would be involved would be paraventricular area. Paraventricular area. So if ventricles are somewhere here in the midline, the lateral ventricles, so the paraventricular area would be affected. That means which area would be affected, upper limb or lower limb? It is the lower limb that would be affected. So this child has affection of the lower limbs, problem of the lower limbs. There is spastic diplegia. Spastic diplegia that you see over here. And this progresses to paraventricular leukomalacia in the future. Paraventricular leukomalacia. Right? This child will form diplegic CP in the future. Apart from that, one more condition I want to discuss, that is kernicterus. What is kernicterus? There are very high level of unconjugated bilirubin. Very high level of unconjugated bilirubin. It can cross the blood-brain barrier of a newborn and cause damage to the basal ganglia. And this child in future is going to have extrapyramidal signs. This is extrapyramidal cerebral palsy or dyskinetic cerebral palsy. So in cerebral palsy, we have read three things: quadriplegia, diplegia and dyskinetic cerebral palsy. Quadriplegia you are going to see in a term baby with parasagittal infarcts and multicystic leukomalacia picture. Diplegic CP you see in preterm babies, intraventricular hemorrhage, there is involvement of the lower limbs, and in future you are going to see paraventricular leukomalacia. And lastly, we have studied about dyskinetic CP or extrapyramidal CP that you see in kernicterus babies. Right? So here the question was asking spastic quadriplegia and the MRI findings. So the MRI findings here would be multicystic encephalomalacia. This you can see in kernicterus picture. This you will see in spastic diplegia picture. And cerebral degeneration will be seen on cerebellar CP. That can be seen at particular infarcts, strokes, right? So this is about cerebral palsy and types of brain injuries that we notice in neonatal age group. So now let's move to the next topic, neonatal seizures question. So we have a 2-day-old newborn with us who presented to you with generalized tonic-clonic seizure. The seizures were not controlled despite phenobarbital and phenytoin. That means you have given 2 types of antiepileptics and seizures are not getting controlled. Which of the following deficiency can be suspected? And we have certain vitamins in the option: pyridoxine, riboflavin, cyanocobalamin, or vitamin C. Which of these vitamin deficiency is associated with neonatal seizures? It is pyridoxine deficiency. Pyridoxine deficiency. Let us understand what all types of neonatal seizures that we see. So when we are talking about neonatal seizures, the most common type is subtle seizures. The name itself says subtle. That means subtle activity you will notice in the newborn. That is seizure. It could be repeated blinking of the eyes, continuous staring look, ocular deviation to one side, or some chewing movements. This is subtle seizure, most common type of neonatal seizures. Then we have focal clonic seizures, we have tonic seizures, we have myoclonic seizures. So best prognosis out of these is of focal clonic seizures, and the worst prognosis is myoclonic seizures. There can be various causes of neonatal seizures. There could be hypoglycemia, there could be some bleed, there could be some meningitis issue. A lot of reasons could be there because of neonatal seizures. But one of the rare causes is the vitamin deficiency. Which vitamin deficiency? Pyridoxine deficiency. In our brain, we have excitatory neurotransmitters and we have inhibitory neurotransmitters. One of such excitatory neurotransmitter is glutamate. This glutamate is converted to inhibitory neurotransmitter GABA by the enzyme GAD, that is glutamic acid decarboxylase. And the cofactor for this pathway, this enzyme, is B6, that is pyridoxine. So if there is pyridoxine deficiency, what will happen? Glutamate levels will increase, substrate will increase, and your inhibitory neurotransmitter will decrease. So there will be too much excitation in the brain that can cause seizures. So whenever you are managing a neonatal seizures and despite giving these antiepileptics, the seizures are not getting controlled, then we give a trial of pyridoxine in the end, because this could be a pyridoxine deficiency. So with this, let's understand the algorithm. Whenever you have a child with neonatal seizures, obviously you are going to do A, B, C. But remember, in neonates, we add T also. TABC. T is for temperature. So in seizure child, firstly you have to do TABC, temperature, airway, breathing, circulation. Most common causes we rule out, that is hypoglycemia, hypocalcemia. So you check the blood sugar, you check the calcium. If blood sugar is low, it's hypoglycemia, we give dextrose bolus. If it is hypocalcemia, again you give calcium gluconate IV. But if both of these come out to be normal, we start with the first line drug of antiepileptic. What is the first line drug? What is also considered a drug of choice of neonatal seizures? It's phenobarbital. So we give phenobarbital. If on phenobarbital the child is also not responding, then we switch to second line drug, which could either be phenytoin or levetiracetam. If not responding to that, then the third line would be continuous infusion of midazolam or diazepam. Right? So continuous infusion comes, and finally, if on continuous infusion also the child is not responding, you are going to give the trial of vitamin that could be responsible for neonatal seizures. So we give a trial of pyridoxine, B6. Right? So this completes this question. This was the basics of neonatal seizures, how you're going to manage it, and which vitamin is notoriously known to cause neonatal seizures. It's B6, pyridoxine, that is notoriously known to cause neonatal seizures. And why neonatal seizures are happening, we also discussed that. The pathway, glutamate to GABA. Right? Let's move to the next question. Grunting is characterized by expiratory sound against the partially closed glottis, inspiratory sound against partially closed glottis, inspiratory sound against nearly closed glottis, and expiratory obstruction at the level of bronchus. So what is the correct answer over here? What is grunting? Grunting is one of the signs of respiratory distress that we notice in newborn babies. What is grunting? So what happens when I am speaking? My vocal cords are moving like this, and because the air is flowing through that vocal cord and my vocal cords are moving, sound is getting produced. So in newborns, in respiratory distress situation, what happens? Grunting happens. This grunting is nothing but expiration against partially closed glottis. Expiration against partially closed glottis. Normally when I inspire, my glottis should open. When I expire, the air has to come out. Again the glottis should be open. But here what the baby is doing, the baby is expiring against a partially closed glottis. That means my glottis is not fully open, it's partially closed at the time of expiration. What will this partially closure do? When my air is trying to escape at the time of expiration, this partially closed glottis will ensure that some of the air is trapped within the lungs, right? So some of the air gets trapped within the lungs. This generates a positive end expiratory pressure. This generates a PEEP. It does not allow the airways to, the alveoli to collapse, right? So it generates a positive airway pressure. This is helping the child in respiratory distress. So understand, grunting is actually a protective sign where the child is expiring against partially closed glottis so that some of the air stays in my lungs, so that the lungs stay open up. So this is expiratory sound against partially closed glottis. Now let's move to the next question. Calculate the Silverman score in a preterm baby who has audible grunting, marked chest and xiphoid retractions, seesaw movements, but no nasal flaring. And the options we have are 7, 8, 9, 10. So this comes to important scores in neonatology. We were just discussing about respiratory distress and grunting. So now let's understand what are the different scores that we apply in neonates for respiratory distress. So whenever a newborn is in respiratory distress, there should be some grade, some score that we should assign. For example, if I am in a night duty, let's say, or you are in a night duty, let's say, and a newborn comes in respiratory distress. You manage the child throughout the night, and by the morning, the respiratory distress has decreased. Consultant comes on rounds and you tell that, sir, night time this child came at 2 a.m. I gave proper management. I woke up the entire night and now the child is improving. But the consultant looks at the baby for the first time. The consultant says, no, the child is still in distress. But you say, but sir, it was actually a lot more in the night. The child is improving. So is there some marker that can tell me that this was 10 in the night and now 5 or 4 in the morning? Is there some marker? There comes the role of Silverman-Anderson score and Downey score, these respiratory distress scores. They will tell you whether your child is improving or deteriorating. If improving, then definitely you can wean off the oxygen support or whatever ventilatory support that you were giving. And if deteriorating, you have to increase your measures. If the child was on CPAP, now you have to intubate, and vice versa. So there comes the role of these respiratory distress scores. They tell us what is the current status of the child, and they will also help me to track whether this respiratory distress is improving or deteriorating. So we have two scores for respiratory distress in newborns. We have Silverman-Anderson score and we have Downey score. So look at the Silverman-Anderson score. Such a big name. This big name is actually for the small babies, the preterm babies. So for preterms, we have Silverman-Anderson score. And for the terms, we have this Downey score. Downey score. So I remember by this that Silverman-Anderson big name is for actually small babies. And Downey score, a small name, actually for a big baby, term baby. So what are the components over here? In Silverman score, we have 5 components. we have upper chest retractions, lower chest retractions, xiphoid retractions, nasal flaring and grunting. These three are very easy to remember. As we go from 0 to 2, the severity of distress is going to increase. So initially you are going to have mild retractions, then moderate, then severe. Same goes for xiphoid, mild, moderate, severe. Same goes for nasal flaring, mild flaring, moderate, marked or severe flaring, 2. Very easy to remember. Let's understand grunting now. If there is no grunting, then 0. If you keep the stethoscope over the chest and you hear grunting, that means if the grunting is audible on auscultation, then it's 1. But if you don't need a stethoscope, you can hear the grunting from the naked ear, this will be 2. So if grunting with the naked ear, audible with naked ear, then its score is 2, right? So if the mother can also hear the grunting, this is definitely stage 2, score 2. And lastly, let's talk about the upper chest retractions. Normally what happens if the baby is lying like this, there is synchronous breathing. That means your chest will move, abdomen will follow. There is synchronous breathing. But if the child is in distress, the child is going to have tachypnea. So this synchronicity will be lost. Firstly, there will be a lag on inspiration, and thereafter there will be this seesaw movement. Chest would be moving up, abdomen down, like the seesaw movement of the chest would be seen. So 0 would be synchronous breathing. In 1, there will be lag on inspiration. And then we have seesaw movement, seesaw breathing. So this is about the Silverman-Anderson score. Now let's go back to the question. We have audible grunting, that means on naked ear, 2. We have marked chest and xiphoid retractions. So for lower chest retractions, +2, xiphoid retractions, +2. We have seesaw movements, again +2. But there is no nasal flaring, 0. So the total score over here is going to be 8. The correct answer here is 8. Right? B8. Now let's talk about this Downey score. They have also asked about Downey score in the exam. So the components of the Downey score can be remembered by the mnemonic GRACE. I have written GRACE over here. This is the mnemonic. G stands for grunting. A is for respiratory rate. A is air entry. C is cyanosis. And R is retractions. So grunting is the same. That if no grunting, 0. If audible with stethoscope, 1. If audible with naked ear, 2. Retractions is also same. Mild retractions, 0. Moderate, 1. Severe, 2. Then comes respiratory rate. The normal respiratory rate of a newborn is 40 to 60 breaths per minute. So if it is less than 60, you're going to say 0. If it is 60 to 80, then 1. And if it is more than 80, then it is 2. Then comes cyanosis. If there is no cyanosis, baby is pink, 0. If there is cyanosis and you give oxygen, cyanosis disappears. This is 1. So if there is cyanosis on just room air, once you give oxygen, the cyanosis disappear. It's 1. But if despite giving oxygen, the cyanosis persists, it's 2. So if there is cyanosis on oxygen, if I deliver 30% of the oxygen and still cyanosis is there, this is 2. And lastly, air entry. If the air entry is equally present, then 0. If the air entry is decreased, 1. And if the air entry is absent, 2. So till now they have not asked about the scoring, but they have definitely asked about the components of the Downey score. So if not anything else, just remember this mnemonic grace: grunting, respiratory rate, air entry, cyanosis and retractions. So let's move to the next question. Next question is the question related to Downey score only. So they have asked which of the following are the components of the Downey score. We have respiratory rate, feeding, grunting, cyanosis. So you know, cyanosis is there, grunting is there, respiratory rate is there. So 1, 3, 4 is the correct answer. Feeding is not a component of Downey score. Right? So let's move to the next question. This is about the INSURE technique. INSURE technique is used in which of the following conditions? Options we have are respiratory distress syndrome, birth asphyxia, neonatal jaundice, transient tachypnea of newborn. What is INSURE? INSURE stands for intubate, surfactant and extubate. And where do we employ this technique? We employ this technique in respiratory distress syndrome. What happens in respiratory distress syndrome? In preterm babies, there is lack of mature surfactant. So these babies are going to have respiratory distress at the time of birth. So we give artificial surfactant in these babies. We intubate the baby, give surfactant through that tube and then extubate. This is the INSURE technique, right? For birth asphyxia, we don't do such things. For neonatal jaundice, we use phototherapy and exchange transfusion. In transient tachypnea of newborn, it is a transient condition, just supportive therapy has to be given. Sooner or later, this child is going to improve on its own. It's a transient condition, right? So now let's move to the next question. Find the incorrect match amongst the following. Maternal lupus, neonatal bradycardia, true. In maternal lupus, SLE, if there is anti-Ro, anti-La antibodies, there are chances this baby can have neonatal heart blocks. Neonatal heart blocks and have neonatal bradycardia. So this is true. Rubella, PDA, rubella, congenital rubella syndrome. PDA is a well-known association, true. Then we have Noonan syndrome. What happens in Noonan syndrome? Noonan syndrome, there is PTPN11 gene mutation. The IQ here is poor. IQ here is poor. And it is the right-sided heart defects that you see. What is on the right side? Right atrium, right ventricle and pulmonary artery. So there is pulmonary stenosis that is seen over here, not bicuspid aortic valve. Bicuspid aortic valve is seen in Turner syndrome. So this is wrong, incorrect match. And then we have DiGeorge syndrome, tetralogy of Fallot, true. We have conotruncal defects in DiGeorge syndrome. So the incorrect match here is C, Noonan syndrome. With that, just let's recap through these associations of congenital heart disease with various genetic syndromes. So the first genetic syndrome we have is Down syndrome. What is Down syndrome? Trisomy 21. We have one extra chromosome 21. Here the congenital heart diseases that we see are endocardial cushion defects. Endocardial cushion defects. Then we have Turner syndrome, that is 45XO. Here we see left-sided heart defects like bicuspid aortic valve, coarctation of aorta. Then we have Noonan syndrome where we see right-sided heart defects like pulmonary stenosis. Then we have Edward and Patau syndrome. Edward is trisomy 18, E for Edward, E for 18. And then we have Patau syndrome, that is trisomy 13. So what are the congenital heart diseases that you see over here? It's VSD. Then we have DiGeorge syndrome. We see conotruncal defects. Then we have Williams where we see supravalvular aortic stenosis. Valvular aortic stenosis. right? So these are the common genetic syndromes with their common associations with congenital heart diseases. Very important table. With that comes another important table. Certain maternal conditions also predispose a child to have congenital heart disease. One of them is gestational diabetes. So in gestational diabetes, the most common congenital heart disease that you see is nothing but VSD. But remember, the most specific association is of TGA, that is transposition of great arteries. Then we have rubella. Here we see congenital rubella syndrome, PDA. If the mother is alcoholic or the mother is taking phenytoin, the baby is going to have fetal alcohol syndrome and fetal hydantoin syndrome. In both of these syndromes, VSD is a commonly associated congenital heart disease. If the mother has bipolar disorder and taking lithium, the baby has chances of which anomaly? Epstein anomaly. Epstein anomaly. And lastly but not the least, if the mother has SLE and anti-Ro antibodies, this child has chances that the child is going to have neonatal lupus. In neonatal lupus, you see heart blocks, so this child will have bradycardia. Right? So these two important tables of CHDs are very important for both your INI exam as well as your NEET PG exam. So don't forget to brush them up just before the exam. Let's move to the next question. NADA's criteria. NADA's criteria are used for assessment of dehydration in children, assessment of children with heart disease, assessment of children with malnutrition, or assessment of children with mental retardation. So remember, this NADA's criteria is devised for the assessment of children with heart disease. Now 2D echos and everything are readily available, but earlier, on the basis of just clinical picture, if we had to make a diagnosis of congenital heart disease, we use this NADA criteria. What is this NADA's criteria? It has two criteria, major and minor. Major and minor. So what are the major criteria? What are the minor criteria? So in major criteria, we have four criteria. The first two criteria are the murmurs. If there is any diastolic murmur, that's major. If there is systolic murmur of grade 3 or more, that's again a major criteria. So the first two criteria are the murmur criteria. Any diastolic or systolic murmur, grade 3 or more. The other two criteria I remember by the mnemonic CC. C for cyanosis, C for congestive cardiac failure, right? So this completes my major criteria. Now let's move to the minor criteria. Systolic murmur grade 3 or more was major. So anything less than grade 3 would be minor. And then abnormal second heart sound, abnormal BP, abnormal ECG, abnormal chest X-ray, all of these investigations, if abnormal, these are the minor criteria. So for diagnosis, I need one major or two minor. This is for congenital heart diseases, right? So this is all you need to know about NADA's criteria. Now let's move to the next question. A 2-year-old boy come with a history of blue lips and blue skin. So that means this child has cyanosis. On auscultation, you revealed a ejection systolic murmur in the pulmonary area. Echo was done on the next day and that revealed TOF, that is tetralogy of Fallot. The severity of the cyanosis and tetralogy of Fallot is dependent upon which of the following. The options we have are the four components of TOF, right ventricular hypertrophy, overwriting of aorta, atrial septal defect, which should be actually VSD, and pulmonary stenosis. What is the correct answer over here? To come to the conclusion, let's understand this very favorite congenital heart disease of INI people, that is tetralogy of Fallot. So what is tetralogy of Fallot? The name itself has tetralogy, tetrad. There are four problems over there in the heart. What are these four problems? We have pulmonary stenosis, we have ventricular septal defect, we have overriding of aorta, and we have right ventricular hypertrophy. So if I make a line diagram over here, this is my heart with the 4 chambers. Right? So there is pulmonary stenosis. This is the right side, this is the left side. So there is pulmonary stenosis, there is overriding aorta coming out, there is VST, there is VST, right? This is right ventricle, left ventricle. There is hypertrophy of the right ventricle. So all the 4 defects I've made: pulmonary stenosis, the right ventricular hypertrophy or VST, and overriding aorta. So what is happening over here? I know the right side of my heart is very important because it delivers the deoxygenated blood to the lungs for oxygenation. So if there is some problem with the right side of the heart and there is shunting of this deoxygenated blood from the right side to the left side, my body is going to receive the deoxygenated blood, and these deoxygenated blood if running through my body, that would lead to cyanosis. So this is what happens in TOF. Because of this pulmonary stenosis, because of this obstruction and this right to left shunting, the baby has cyanosis. And what is important here to understand is TET spells, TET spells. So what happens in TET spells? In under a stressful situation, hypoxia, this pulmonary stenosis will further worsen. There will be infundibular spasm. And because of this infundibular spasm, what will happen? The blood won't go into my lungs through this pulmonary channel. There will be more shunting, more right to left shunting, leading to more cyanosis. And this continues this vicious cycle. So in TET spells, in cases of hypoxia or stress, there's going to be infundibular spasm. So there will be worsening of the pulmonary stenosis that again leads to cyanosis, more right to left shunt, and this vicious cycle continues. So this is TET spells. So this answers our question. Pulmonary stenosis guides the severity of cyanosis. But what is important for us here to understand is the management of this TET spell, how you're going to manage. The first thing in the management of TET spells is take the child into a squatting position or in a knee chest position. So the first management here is squatting or knee chest position. What happens in the squatting or knee chest position? By keeping this child in squatting or knee chest position, there will be compression of the femoral vessels, femoral artery and femoral veins. So by compression of the femoral vein, there will be decrease in this return. So that means the load on the right side will decrease, the right sided pressures will decrease, and with the compression of the femoral arteries, what will happen? The systemic vascular resistance will increase. That means my left sided pressures will increase. So that will decrease my right to left shunting, because now the left sided pressures are more than the right sided pressures. So this will decrease the shunt and the cyanosis will disappear. Right? The second thing that we do is giving beta blockers or alpha agonists to increase the systemic vascular resistance. And the definitive treatment here would be surgery. What we do? We make a channel connecting the systemic and the pulmonary circulation. This shunt is known as Belloc-Taussig shunt. In Belloc-Taussig shunt, you're going to connect this pulmonary artery with the subclavian artery. This is Belloc-Taussig shunt. Apart from that, 2 other shunts are also there: Watterson shunt, Pott shunt. In Watterson, we connect with the ascending aorta, and in Potts with the descending aorta. So we won't go further into details. Just remember, TOF is a very important topic. The clinical triad, the tetrad, the TET spells, this is all that they expect you in the exam. And if they ask you the definitive treatment or the surgical management, that would be this BT shunt, Belloc-Taussig shunt. right? So now let's move to the next question. What was not included in the Turner syndrome? So Turner syndrome 45XO, they're asking about the constellation of the symptoms, which is not there. Short fourth metacarpal, we see that. Widely spaced nipple, we see that. Webbed neck, we see that. Prominent occiput. Prominent occiput is not included in the Turner syndrome. We actually see a low hairline in these Turner syndrome patients. So let us revise these Turner syndrome. Turner syndrome, it is an aneuploidy. We have 45XO, one less chromosome. We don't have a Y over here, so Turner syndrome are going to be girls exclusively. But they have non-functional ovaries, streak ovaries, so they will present with amenorrhea, infertility. Apart from that, there is low hairline, droopy eyelids, widely spaced nipples, right-sided heart defects, kidney problems also, horseshoe kidneys, streak ovaries. They have a particular habitus. They have a carrying angle, the elbow deformity. Fourth metacarpal is short. Right? So these are the features of Turner syndrome. Now let's move to the next question. Which of the following blood gas and electrolyte collaborate with IHPS? What is IHPS? IHPS stands for idiopathic hypertrophic pyloric stenosis. Right? Idiopathic hypertrophic pyloric stenosis. So let's understand what happens exactly in this deformity. If this is my stomach, the condition itself says hypertrophic pyloric stenosis. This is my fundal end that is connected to the esophagus, and then we have the pyloric end which goes down into the duodenum. So there is hypertrophy of this pyloric areas. So there is hypertrophic of actually the circular muscles in the pylorus end. So what will happen because of the hypertrophy? The lumen will be constricted. There will be gastric outlet obstruction. So what happens in this child? By week 2nd or 3rd of life, because of this obstruction, the food cannot go through. So there will be recurrent vomiting. And what type of vomiting will be there? Will it be bilious or non-bilious? The bile is secreted down here and through the duodenum. So here there will be recurrent non-bilious vomiting. So there is recurrent non-bilious vomiting of projectile nature. This starts around 2nd to 3rd week of life. And usually it is seen in the first-born males. First-born male childs. So what is the problem? What are the electrolyte imbalances that we see over here? If there are recurrent vomiting, so all my gastric juices would be vomiting out. So there will be loss of HCl, gastric acid, loss of sodium, loss of water. So let's see what will happen. If there is loss of your HCl, there will be loss of H+, loss of chloride. So loss of H+ means acid is going out from my body. There will be metabolic alkalosis. There will be hypochloremia. And what about the loss of this sodium and water? This child will be very dehydrated. Right, very dehydrated. And whenever there is loss of sodium and water from my body, what will happen? Which system gets activated? My RAS will be activated. Renal angiotensin system will be activated. And by this we release the aldosterone. There will be conservation of the sodium and release of H+, K+. H+, K+ would be excreted. So my body is in alkalosis. So my body should conserve H+, but my body is excreting H+. So that's why this is known as paradoxical aciduria. So if you look at the complete picture, what are we seeing over here? We are seeing hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. Paradoxical aciduria. So this is the picture that we see over here in CHPS or congenital hypertrophic pyloric stenosis. So let's see which of these fits. We know there is going to be metabolic alkalosis. So alkalosis are these two options. Then I know there is going to be hypokalemia. This is hyperkalemia, hypokalemia, right? So the correct answer would be this, option C. There is hypokalemic, hypochloremic metabolic alkalosis with paradoxical aciduria. Right? This is about CHPS. They also ask what are the ultrasound findings that you see over here. So in ultrasound, what do? We focus on the pyloric end. If the thickness of the pyloric end is more than 4 mm, or the length is more than 16 mm, it is suggestive of congenital hypertrophic pyloric stenosis. And the sign that we see on barium swallow is the mushroom sign or string sign. Mushroom sign or string sign. The treatment is initially we have to manage the child, correct the dehydration, correct the electrolyte imbalances, and then take up for surgery. We do pyloromyotomy, that is also named as Ramstedt pyloromyotomy. This you must have studied in surgery too. So now let's move to the next question. We have a 6-year-old child that presents to us with the symptoms of dehydration. You are evaluating the clinical signs to confirm the diagnosis. Which of the following is a reliable sign of some dehydration in a severe acute malnutrition child? The options we have are increased thirst, sunken eyes, skin pinch that goes back slowly, and altered sensorium. So to answer this question, let's first understand the dehydration assessment and the management, and then we will pick up this question. So how do you assess dehydration? We have 3 categories: no dehydration, some dehydration, severe dehydration. So next time a child comes to you with vomiting and diarrhea, the first thing that you are going to do is assess the status of dehydration. If there is no dehydration, that means there is no dehydration in the body of the child. This child would be looking very alert to you. The thirst here would be normal. That means if you offer water to this child will calmly drink water like a gentleman. There is no dehydration, normal thirst is there. If you do skin pinch, it will go rapidly, right? So there will be fast recoil. If you look at the eyes, they will look normal to you. Here we give plan A of the treatment. Then we have some dehydration. Now some degree of dehydration has started. So whenever some degree of dehydration starts, this child will become very irritable. Very irritable child, very chidchida, very irritable child. If you offer water to this child will drink eagerly. Child will be very thirsty. So an irritable child with increased thirst is some dehydration. If you look at the skin pinch, it will go slowly, but usually within 2 seconds it will come back. If you look at the eyes, the sunken eyes would be there. And plan of treatment here we give is plan B. Then we have severe dehydration. Now the child is severely dehydrated. So this child would now be very lethargic, very comatose, not responding, comatose, lethargic. So if you offer water to this lethargic comatose child, will he drink? No, he will be unable to drink. So thirst either I can say decreased or unable to drink. The skin pinch here will be very severely delayed, more than 2 seconds. Eyes will look very, very sunken. Here the plan of treatment that we go for is plan C. Plan C. right? Now let's understand this plan A, plan B and plan C. What is plan A? Plan A was for no dehydration. This child does not have dehydration, is calmly drinking water. So what can I do? I give ORS over here to this child, an oral treatment, and this child can be managed at home. I tell the mother, your child has no dehydration. You just have to replace the ongoing losses. How do we replace? Usually 10 ml per kg per loose stool. Per loose stool. This is how we manage no dehydration. When we talk about some dehydration, we go to plan B. Here also the child can eagerly drink water. So I don't need to give IV fluids to this child. I will again give ORS to this child. Here, but I have to rehydrate. There is some degree of dehydration, so we have to rehydrate. How do we rehydrate? We give 75 ml per kg of ORS over 4 hours. Along with that, we have to ensure that again 10 ml per kg replacement of losses would be there, and ensure that maintenance fluids are given to this child. What are the maintenance fluid? Maintenance fluid is just what we all need per day, depending upon the weight of the child. You and me also, we need a maintenance fluid every day. That amount we have to ensure that the child is receiving. Plan C is for severe dehydration. This child cannot take anything by water, by mouth. So here we give IV RL, ringer lactate. Here the rehydration is different. We give 100 ml per kg, 100 ml per kg. This is given in 2 blocks. Firstly 30 ml per kg bolus, then 70 ml per kg. If the child is very small, less than 1 year, then I have to give rehydration very slowly. So initially over 1 hour you give this 30 ml per kg, then over 5 hours you give this 70 ml per kg. If the child is above 1 year of age, then half of that. In 30 minutes you give this 30 ml per kg, and in 2.5 hours you give 70 ml per kg. And then replacement of losses and maintenance fluid will be usual, right? So this is all about the dehydration assessment and management. Now let's come back to the question. In this scenario, they have given us a 6-year-old child with symptoms of dehydration. And they're asking which of these is a reliable sign for some dehydration in severe acute malnutrition. So I know in some dehydration, increased thirst is there, sunken eyes is there, slow skin pinch is there, altered sensorium is a severe dehydration. So one option I have excluded. Now let's look at the 3 other options. If it is a normal child, then all of these would be there. But the question says severe acute malnutrition. That means this child is severely wasted. That means no subcutaneous fat whatsoever. So if I do skin pinch over here, then because the skin fat is already very less, this won't be reliable sign. I will overestimate dehydration by skin pinch. Right? Normally, if the hydration status is good, but there is no subcutaneous fat within the skin, the pinch would be slow only. So this is not reliable. Same goes for eyes. If there is no fat over the face, the eyes would look sunken to me. So this is again not a reliable sign. The thirst would be a reliable sign over there. Right? So remember, in SAM babies, just by looking at the baby, we can overestimate dehydration because they don't have fat. But thirst is a sign that if increased can suggest some dehydration. So remember, in severe acute malnutrition, we use this thirst for some dehydration. Another reliable marker would be mucosal, checking the mucosal moisture. What do? We check whether the oral mucosa is moist or not. Gently insinuate your finger and check the oral mucosa. If it is dry, it is some dehydration. If it is very dry, it's severe dehydration. So here the most appropriate answer is going to be increased thirst in a severely acute malnourished child. Right? Now let's move to the next question. We were just talking about the dehydration in SAM babies, and now we have the rehydration solution for the SAM babies. So they are asking what is the glucose content of Risomol. The options we have are 100 millimole per liter, 125 millimole per liter, 150 millimole per liter, and 75 millimole per liter. So what is Risomol? Risomol stands for rehydration solution for the malnourished. So if the nutritional status of a child is good, we can give normal WHO ORS. But in malnourished children, they have essentially problem with handling of sodium. They can't handle too much sodium. So we need a replacement. We need low sodium. Also, these children are prone to hypoglycemia. So I need more glucose. And also, in malnourished children, there is potassium and magnesium deficiency. So I also need more of potassium and magnesium. So instead of ORS, we give this modified solution, that is Risomol, which has low sodium, high glucose, high potassium, and higher magnesium as compared to your normal WHO ORS. So in normal WHO ORS, I know magnesium is not there, so we have added magnesium in Risomol. So in normal WHO ORS, what all do you have? You have sodium, you have glucose, you have potassium, you have citrate, right? And you have chloride. So let's look at the differences over here. In WHO ORS, you all know what are the concentrations. Sodium and glucose are equal, 75-75. Potassium is 20. Chloride and citrate if added together again become 75. So chloride is 65, citrate is 10. So total osmolality is 245 milliosmoles. In Risomol, I told you what has to be decreased? Sodium has to be decreased. So sodium is 45. Glucose has to be increased, 125. Potassium has to be increased, 40. Right? And rest we add magnesium. Chloride and citrate are somewhat similar only. Then the total osmolarity becomes 300. So in this question, they were asking about the glucose content. It's 125. Right? So remember this table of differences between your normal WHO ORS and Risomol. Now let's move to the next question. A child presents to your clinic with 3 days of vomiting, watery diarrhea, and altered sensorium. So basically there is a child with vomiting, loose stools, and now the child has altered sensorium. So they're asking the possible diagnosis here includes hypernatremia, hyponatremia, cerebral venous thrombosis, or HUS. So basically they're asking the causes of altered sensorium in a child with watery diarrhea. So remember, whenever you encounter such a picture, an altered sensorium or seizures in a child with this vomiting loose stools, you have to think of these 8 conditions. These are taken from Ghai textbook only. They have actually numbered these 8 conditions. So what are these 8 conditions? First condition is hypohypernatremia. That means both, either high sodium or low sodium. Then hypoglycemia, less sugar. Then hypocalcemia, especially following bicarbonate therapy that we give for acidosis. Encephalitis, meningitis, febrile seizures, and cerebral venous or sagittal sinus thrombosis. So these are the main causes for convulsions or altered sensorium in cases of vomiting loose stools. So hypernatremia, hyponatremia, cerebral venous thrombosis, all of these would be correct. So the correct answer here is 1, 2, 3. Very easy to remember. High sodium, low sodium, hypocalcemia, meningitis, encephalitis, cerebral venous thrombosis, or sagittal sinus thrombosis. These are major things. Now let's move to the next question. Infection of the airway. A 4-year-old child presented to you in the emergency with stridor, respiratory distress. There is noisy breathing and drooling of saliva. The emergency X-ray showed thumb sign. What is the diagnosis over here? Options we have are croup, acute epiglottitis, foreign body aspiration, retropharyngeal abscess. So the question has straight away given you stridor, there is respiratory difficulty, drooling of saliva, and typical X-ray sign, that is thumb sign. This is nothing but acute epiglottitis. So this is an overlap topic with ENT and pediatrics, but an important one. So let's understand acute epiglottitis. What is the age group in which you see this acute epiglottitis? 1 to 3 years of age. And the cause here is bacteria, that is H. influenza type B. Here the child would be very toxic looking, high grade fever, muffled voice, there is drooling of saliva, and a typical position in which this child sits down is this position, tripod position. And what is the typical sign that you see? Thumb sign. Normally epiglottitis will look like this, but here on the lateral X-ray of the neck, the epiglottitis would be swollen. So this is known as thumb sign. This is known as thumb sign. The treatment would be to do the immediate management, airway, breathing, circulation, and start with antibiotics. We start with third generation cephalosporin. So this is all about epiglottitis. Now let's understand about the sister condition, that is LTB or croup, laryngotracheobronchitis or croup. Here the age group is overlapping, 6 months to 5 years of age, but it is a viral condition caused by para-influenza virus. This child won't be that sick. There will be low-grade fever, stridor, and a typical cough with which its name comes. There's barking cough or brassy cough or seal-like cough. This is croup. We classify croup into 3 categories depending upon the severity. If there is just stridor on exertion, this will be mild croup. This child won't have any respiratory distress sign. The saturation would be normal. We just give a single dose of oral dexamethasone over here. In moderate croup, here the stridor will be appreciated at rest. And along with that, there can be signs of respiratory distress like retractions, increase in the respiratory rate. The saturation here stays normal. And in severe condition, along with these signs, now the saturation would also be affected. So in these both moderate and severe conditions, we give oxygen inhalation and nebulization with racemic mixture of epinephrine. Here in the X-ray sign, you will see narrowing, that is known as steeple sign or pencil tip sign or temple head sign. Different names are given. So these are the 2 conditions, 2 infections of the airway that you have to be very well versed with. So this completes our question. Let's move to the next question. We have a 10-month-old infant who presents with cough and fever for 3 days. On examination, the respiratory rate of this child is 56 breaths per minute. There is no chest indrawing, no danger signs. According to the INCI guidelines, this child should be classified and managed. The options are severe pneumonia, admit this child and start injectable antibiotics. Pneumonia, start oral antibiotics. No pneumonia, give home care and counsel the mother. What would be the correct answer over here? For that, now let's just revise the INCI guidelines for pneumonia. Before going into the INCI guidelines, you should know what is the criteria for fast breathing and what are the danger signs. So what is fast breathing? If the respiratory rate is more than 60, 0 to 2 months of age, 2 to 12 months, more than 50, after 12 months, more than 40. So 60, 50, 40, remember. Less than 2 months, more than 60, 2 to 12, more than 50, after 12, more than 40. This is the criteria for fast breathing. What are the danger signs? If the child is unable to drink, that's a danger sign. If the child has seizures, convulsions, that's a danger sign. If it is a calm child but you appreciate stridor, that's a danger sign. If the child is abnormally sleepy, danger sign. If there is severe malnutrition, danger sign. So remember these 5 danger signs: unable to drink, convulsions, stridor in a calm child, abnormally sleepy child, or severely malnourished child. With these basics, now let's understand what is no pneumonia, pneumonia, severe pneumonia. So in no pneumonia, what do you see? You just see this upper respiratory symptoms, that is cold, cough, fever. There will be no sign of respiratory distress. That means no tachypnea, no retractions, no chest indrawing, and the saturation here will be normal. This child just needs some soothing treatments. So here we just give supportive treatment. We say give adequate hydration. We can add on nebulization with salbutamol if there is wheeze. That's it. Nothing else to be given. No antibiotic has to be given. This child has no pneumonia. What happens in pneumonia? Either there will be fast breathing. The criteria of fast breathing, you know, more than 60, 50, 40, less than 2 months, 2 to 12 months, after 12 months, or there will be retractions. Or an ANT, there will be retractions. Here the saturation is again normal. So here I know there is some respiratory distress, there is pneumonia. So here we give antibiotic, but this antibiotic is oral antibiotic at home. We add amoxicillin for 5 days and we tell the caregiver about the danger signs. That if danger signs happen, please report back to the emergency. And we also follow back after the 5 days course of antibiotic. Lastly comes your severe pneumonia. Whenever there is danger sign, then we label this child as severe pneumonia. In severe pneumonia, you have to give injectable antibiotic and refer the child to the higher center for management. Refer to higher center for management. Right? So now that we know the IMNCI guideline, let's move back to our question. Our question gave us a 10-month-old child and the respiratory rate was 56. So is this normal or abnormal? I know less than 2 months was more than 60. 2 to 12 months was more than 50. So definitely this child has fast breathing. But there is no chest withdrawing and there is no danger sign. So this means this child has pneumonia. Here you have to start oral antibiotic and home management. Just if you want a tip from my side, then whenever such a question is happening now, look for danger sign. If any of the points you spot, if there is some danger sign, then definitely mark severe pneumonia. If no danger sign is there and just fast breathing or chest indrawing is there, mark pneumonia. If no such chest indrawing and the tachypnea is there, fast breathing is there, then it's going to be no pneumonia. So very important question, very frequently asked question, important for your exam. Now let's move to the next question, a micronutrient deficiency question. In Menkes disease, there is a disorder of copper, zinc, iron, selenium. Menkes disease, we all know it's copper deficiency. What is zinc deficiency? Acrodermatitis enteropathica. Iron deficiency leads to your iron deficiency anemia and other problems. Selenium deficiency leads to Keshan's disease that affects my heart, cardiomyopathy and bones arthritis. So let's have some words about Menkes disease. It is an X-linked recessive condition, so that means boys would be more prone. The genetic defect here is in the ATP7A gene, right? Here, because of this problem, what happens? There is problem in the absorption of copper from the gut. That's why there is copper deficiency. And this child has characteristic kinky hair pattern, neuropathies. This is Menkes disease. Let's move to the next question. Which of the following vaccines cannot be given to the child with SCID? Severe combined immunodeficiency. The options we have are Tdap, hepatitis B, MMR, IPV. Remember, in children with primary immunodeficiencies, we don't give live vaccines. Live vaccines are contraindicated. So which is the live vaccine in this option? MMR. So we don't give MMR to these babies. Straight away question, factual question. Let's move to the next question. A child received DPT vaccine at 6 weeks, okay, and cried inconsolably after the vaccination. Now the child is 10 weeks. That means the second dose time has come. What is the best step here? Don't give DPT, give DPT, only give DT, only give TT. So let's understand about this DPT vaccine and its adverse effects. So when we talk about DPT vaccines, DPT vaccine has three things. We have diphtheria toxin, tetanus toxin, and pertussis. Pertussis could be whole cell or acellular. Whole cell has more reactions. At that point, that there will be more local pain, swelling, fever. These things are more associated with the whole cell variant as compared to the acellular variant. That's why in the market you see the fancy names like painless vaccine. So this painless vaccine is actually the acellular vaccine. It's not actually painless. Whenever the needle is going to go, the baby is going to cry, but there will be less signs of inflammation locally. So that's why they call it as painless vaccine. So the common side effects that we see with this DPT vaccine are nothing but local pain, fever, swelling, and sometimes some rare side effects are noted. What are these? HHE, that is hypotensive hyporesponsive episode. Hypotensive hyporesponsive episode. Then inconsolable cry, baby crying for more than 3 hours. Hyperpyrexia, fever more than 40.5 degrees Celsius. Seizures, encephalopathy. So these are some of the rare side effects, adverse effects that are noted with DPT vaccines, right? Now comes the contraindications when you are not going to give this DPT vaccine. If in the previous dose there was a severe reaction or anaphylaxis, that is a contraindication. And if there was encephalopathy in that previous dose, this is contraindication. So these two are absolute contraindications. If there was anaphylaxis or encephalopathy, I won't give the next dose. And there is a relative contraindication also. If there is progressive neurological disease following this DPT vaccine, then in the next dose you are going to omit the pertussis component, because this pertussis component is responsible mostly for this neurological side effect. So either we give DT or TD, DT or TD, right? So these are the contraindications. Remember, if the child has stable neurological disease like developmental delay, cerebral palsy, idiopathic epilepsy, then they can receive the vaccine. Just in cases of progressive neurological disease, you have to omit the pertussis component. This was all about contraindications. Now there is something known as precautions. What do I mean by precautions? Precautions are those things whenever such precautionary steps happen, precautionary adverse effect happen, then what do? When the next dose comes, we take precaution and give that dose. If in that subsequent dose again the things repeat, then we have to stop and further dosage, right? So these precautions include fever more than 40.5 within 48 hours of the dose, hypotensive hyperresponsive episode within 48 hours, persistent inconsolable cry for more than 3 hours within 48 hours, seizures within 72 hours. So if any of these events listed out here happens with the subsequent dose, then further doses will be contraindicated, right? So this is what the examiner was trying to test over here. The examiner gave us a precautionary thing that this child cried inconsolably, right? This is one of the precautionary event. So whenever such a precautionary event happens, the next dose I am going to give. If this repeats, further doses will be contraindicated. So the correct answer over here would be give DPT. Give DPT to this child. Right? B. Option B. Give DPT. Now let's move to the next question. We have a 5-year-old over here who presented to us with hepatosplenomegaly and cherry red spot. This child exhibit an abnormal startle response and developmental regression. Which enzyme is deficient? The options we have are sphingomyelinase, glucocerebrosidase A, and aryl sulfatase hexosaminidase. So what is this typical picture? What is this typical picture? Developmental regression, cherry red spot, abnormal startle. This is very pathognomonic, abnormal startle. What is this disease? This is nothing but Tay-Sachs, right? This is Tay-Sachs disease, and we all know what is the enzyme that is deficient. Hexosaminidase. Let's explore other options too. Sphingomyelinase. Sphingomyelinase deficiency, where do you see this? we see in Niemann-Pick's disease. Niemann-Pick. So what is going against Niemann-Pick? In Niemann-Pick, we see hepatosplenomegaly, we see cherry red spot also sometimes, but the startle response and developmental regression, this is not commonly seen. We see more of the systemic features rather than neurological features. So this is omitted out. Then we have glucocerebrosidase A deficiency. Where do you see this? We see this in Gaucher's disease. So hepatosplenomegaly is seen over here, pancytopenia is seen over here, but no cherry red spot, no startle response, no neuroregression or developmental regression. So again, this would be omitted out. Then we have aryl sulfatase deficiency. This we see in metachromatic leukodystrophy. So what do we see over here? Metachromatic leukodystrophy, we see demyelination features. So definitely we will see developmental regression, but no cherry red spot, no hepatosplenomegaly. So again, we can omit this option out. The most appropriate over here is hexosaminidase A deficiency. Right. So with that, we end our session. If there is any doubt regarding any of these questions, or any other doubt, then I will be more than happy to answer over here. Please drop that in the comment section. If no other doubt is there, then we can end this session. I hope this session was helpful. I curated the session in such a way that the most important PYQs and PYTs over the last 5 to 10 years are covered. And INI exam is such a PYQ heavy exam, PYT heavy exam, that if you're not going through previous year questions, you are definitely doing something wrong in your preparation. So definitely do watch other subjects PYQ marathon also, and this pediatrics one, at least these questions please do cover, and the topics that I have focused on, please reread that topic through your notes too, because anything can be covered. The topics would be same, the concepts they test would be the same. So anything you want me to cover again, I'll be more than happy to cover. If not, we can end this session and have dinners and enjoy our Sunday evening. Now is the